Hello, if you're just joining us, we're just going to wait a couple more minutes. If you need translation, please click on the interpretation button at the bottom of your Zoom screen and assign yourself to the right channel. Good morning, good afternoon, good evening, and welcome. Hi, everybody. I am Mary Beth Hastings. I'm the Senior Gender Advisor for FP 2030, and I use she, her pronouns. I'm so glad that you could join us for this Women Deliver Global Dialogue community event. Thank you so much for spending some time with us as we all get excited about coming together in Kigali or through the virtual conference in just a few weeks. And thanks to the team at Women Deliver for co-hosting this webinar and for all their efforts in building up to the conference. So we just wanted to start with some housekeeping items before we begin. As a reminder, this webinar will be recorded and it is also being interpreted in French and Spanish. So to select your language, just click on the globe icon on the bottom of your Zoom window and you can choose the appropriate channel. We will have a presentation in Spanish. So if you don't understand Spanish, just click on the globe and select the channel for English. The title of today's webinar is Decolonizing Reproduction, Resisting Reproductive Violence Across Contexts. This topic is timely and urgent. The lingering effects of colonization are so deeply embedded within structures, policies, relationships, and that generates opposition to sexual and reproductive health and rights across the globe. But this isn't just a conceptual discussion. Decolonization and the resistance to reproductive violence have real programmatic research and policy implications, and we hope to delve into that today. For FP 2030, this is particularly timely as we've just released our new gender strategy, and I'll share more about that strategy as we close. In just a moment, we are going to hear from Dr. Semukalezo Dube, our FP 2030 Executive Director, and she'll have some opening remarks for us. We'll then have our panelists each present on different experiences of and resistance to reproductive violence. And then we'll invite panelists to respond to your questions. So please put your questions in the chat, and we hope to have a lively and interesting discussion. Thanks again for joining us. Dr. Samu, over to you.
Thank you so much, Mary Beth, and I hope everybody is well. So good morning, good afternoon, and good evening to wherever you are in the world. Just acknowledging Mary Beth, my fellow panelists who are going to be here today. So my name, as Mary Beth has said, my name is Samu Dube, and I'm the Executive Director for FP 2030. Just delighted as we are preparing for Kigali for Women Deliver, and thank you so much, Women Deliver, for your partnership in this particular webinar. I think this meeting, as you said, Mary Beth, comes for me and for hopefully the movement. It comes at a very critical time and moment in our history. you would know that we are at an intersection of several global crises. You know, there is a paper that came out a few weeks ago from the WHO around maternal mortality declines that have plateaued across the globe. So we know that globally, 800 women continue to die every single day in childbirth. Now, this is also compounded by the fact that 218 million women across the globe still have what we're calling an unmet need for contraception. That means that they want to avoid pregnancy, but they are not using any modern method for one reason or for another. Research also shows that as a key metrics around gender equality, that they are not progressing, but they are eroding. And there's been an estimated timeline for some of you who are following this closely like myself, that we need at least 132 more years if we are moving at this pace for us to attain gender equality. Now, we know also that nearly half of the world's people believe that men make better political leaders than women do. And that is a surprise to me because evidence points to the contrary. And because of these gendered power dynamics that we see all around us, funding for family planning programs, for contraceptive programs, for reproductive health across the globe, it remains deprioritized. It is difficult to secure and overly politicized because being female, as many of you know, for over centuries has been denigrated to conformity, to submission, to something, or it has been classified as something that is not worthy of being a primary subject or a primary discussion point in many settings. Who makes the decision, ladies and gentlemen, around allocation of finances in many countries across the globe? And that is important. And at the core of that is why this subject that we are discussing today matters. The problems that we articulate have got deeper roots. Colonialism, as many of you know, has a legacy of exploitation. It is a legacy of patriarchy, power imbalances, and cultural erasure in many settings. And it has profoundly shaped our societies and institutions as we see and know them today. What we know as modern medicine, many of you who have practiced that, has progressed through a combination of colonization and as well as contributions and exploitation of marginalized groups across the globe. We now know that not only did groundbreaking discoveries depend upon these marginalized groups being subjects of experimentation, but also that many revolutionary or perhaps evolutionary ideas, colleagues, from early vaccination to the use of forceps delivery that we use in obstetric care today, were taken from many marginalized groups without consent and without credit. Because of this history, we cannot move forward without transparency in every new scientific endeavor. We need to acknowledge and include women and other marginalized groups in a voluntary rights-based approach of advancement of science. I believe not only has colonization shaped medicine and how healthcare is provided today, but it has also shown up in the early ideologies about modern contraception, which was often employed by colonial powers as a tool to control rather than to empower. The remnants of this ideology persist today. It shows up in the assumption that people, women, families cannot make good reproductive decisions on their own. And this is problematic. And in the arrogance of a government, we see it where even some donors also may supplant their judgment for that of an individual or couple's judgment. This is problematic in many levels because we believe at FP 2030 that reproductive autonomy should be a fundamental human right, including comprehensive access to health education, contraception, safe abortion care, Yet, we know in many settings where we exist, silos, social norms, and stigmas driven by exacerbated colonialism are built to ensure members of our communities, like young people, we believe should be a strategic pillar of our organizing as FP 2030. Indigenous populations in many places across the globe, people with disabilities, low income and rural communities, and LGBTI people are excluded or even punished for exercising their own rights. People's lives may be at risk just for seeking the healthcare they need and deserve. The stakes couldn't be higher. Ladies and gentlemen, decolonizing reproductive health requires all of us to recognize and challenge the power structures that perpetuate these injustices and the legacy of policies and programs that take away reproductive choice. Colonialism brought, amongst many of us, the power that of government and legal systems into reproductive health decisions like abortion that used to be considered private. If you read literature, you would attest that in many states, whether it's in Lesotho, whether it's in Nigeria, issues such as access to abortion were actually left to women to decide and not to a judicial court. Decolonizing involves us acknowledging the policies created in tied colonialism that curtail reproductive rights and purposefully deconstructing them. That's the duty that you and I need to play in this particular narrative. For FP 2030, deconstructing these structures started with the very structure of our partnership. You would know, as if you're following and working with us closely, that we were once a secretariat that was based in Washington, D.C., and we're focusing on increasing access to family planning in 69 focus countries. But now we've shifted to truly a global support network with regional hubs in Nairobi, in Abuja, in Kuala Lumpur, in Panama City, and in Washington, D.C. And this partnership, colleagues, is open to all countries and all stakeholders who are willing to work for reproductive autonomy. Each regional hub is hosted by a unique organization with a managing director leading it, who has deep ties to region and family planning movement. FP 2030 keeps the best of what we did in FP 2020, the convening power of the partnerships, collaborative platforms, our dedication to high quality data and evidence. And this matters because we believe that if we don't measure what we do intentionally, really the story is not going to be told accurately. We also believe, and we're going to keep the steadfast commitment to the rights and needs of women and girls across the world, whilst embracing changes that emphasize country leadership, inclusion, equity, transparency, and mutual accountability. This organizing, we believe, will help us move forward as we talk about decolonization in the work that we do. We believe that this shift is vital to putting power in the hands of those whose rights matter most for you and I. Decolonization also demands that we critically examine the cultural biases that are embedded within global health. We need to consistently interrogate what problem are we trying to solve? Who is part of making that determination? And colleagues, who benefits from that determination? We must continue to insist on rights-based approaches, and we must continue to ensure that our work, your work, centers the agency of those who are most affected. As we know from the pedagogy of the oppressed, that we need to be mindful of who tells the story and how are they telling that particular story. There is another crucial aspect of decolonizing reproductive health, which is about dismantling the economic barriers that prevent marginalized communities from accessing quality health services. I believe that we must address these systemic inequities in healthcare systems that limit affordability, such as the lack of insurance coverage, discriminatory policies, and inadequate funding for reproductive health programs. As we all advance universal health coverage, are we sure that affordability of reproductive health is at the core and is the pillar of what universal health coverage entails? Only by ensuring gender transformative universal health coverage that includes family planning can we truly advance reproductive health. This is really not a big ask for you and I. Decolonization finally demands that we center the voices and experiences of marginalized communities in policy making we amplify the stories of those who have been silenced, those recognizing their agency and incorporating their perspectives into decision-making processes. Communities that lead initiatives and the grassroots organizations that work in places where we are play a vital role in advocating for change and ensuring that the solutions we develop are relevant, they are inclusive, and they are effective. We can't make progress alone. We join with gender equality and feminist organizations, climate change organizations, those who are working on the rights of LGBTI people, and those who are working people with disabilities. If people cannot make their own reproductive decisions, they cannot fully participate in their communities. Girls cannot stay in school. Women cannot achieve their true potential and their career aspirations. We cannot make progress on SDGs if we don't include progress on rights-based sexual and reproductive health. Time is of essence. We are nearing that midpoint of SDGs and generation equality. And we know as a global community that many of these goals are off track, particularly SDG 5. We have to end the business as usual and make radical changes in how we work together. Now, what is the way forward, ladies and gentlemen? First, we need to ensure that programs and policies subscribe to the ethics of inclusive equality when it comes to reproductive health. Decolonization is not something intangible, and it does not mean better rights for the previously colonized. Rather, it is something that every institution, every organization, and every person involved in the reproductive health field must commit to and live out. It includes a close examination of family planning method mixes that have a colonial legacy. Second, we must repeat the mantra of nothing about us without us in everything that we do. We need faster and urgent progress on centering voices of young people in reproductive health decision-making and change towards gender equality. This means well-funded feminist civil society groups, and that these should actually serve as guardrails for rights-based family planning. For those groups, are you able to join us as engines of changing gender norms and drivers of government investments? Thirdly, we need governments to actively engage in decolonization. Reviewing policies that are rooted in colonialism, that have suppressed citizens' reproductive autonomy, is the first step. In many of these countries, ladies and gentlemen, I have reviewed some of the reproductive health policies, abortion laws, that as archaic as in they have been in existence for more than 100 years. We need proactively to fund reproductive health delivery and research in consultation with civil society that would promise to transform health systems. Let us confront legacies of colonialism and active work towards building a world where everyone can freely determine their reproductive future without stigma. We are united in the fight for human rights. By recognizing and respecting each other's agency, we can create systems that are truly inclusive, equitable, empowering, and address the needs of whole individuals. I know we are all stronger together. And thank you. Over to you, Mary Beth.
Thank you so much, Samu, for those inspiring and challenging words. I think you've set the stage beautifully for our panelists, and we really appreciate your being with us today. We know that you need to go off to another meeting, but we're so glad that you were able to be here and offer those words to us all. Now we're going to turn to our panelists to hear their perspectives on this issue. First, we're going to hear from Evelyn Apondo. Evelyn is the director of ICRW Africa, and she has over 20 years of experience in gender issues, human rights, law, and sexual and reproductive health and rights. She also serves on FP 2030's governing board, and we are so grateful for her leadership. Prior to joining ICRW, Evelyn served as the Senior Regional Director for Africa at the Center for Reproductive Rights, based in Nairobi, Kenya. In this role, she was responsible for developing, communicating, and executing strategies, as well as mobilizing resources to ensure successful delivery and sustainability of the mandate of the Center in Africa. Evelyn, over to you.
Thank you, Mary Beth, and good afternoon, good morning, wherever you are. I will be speaking about the political context of attacks against bodily autonomy and the backlash that we are witnessing. Now, attacks on bodily autonomy stem from conservative ideologies that seek to maintain traditional roles and power structures. And they are based on they view gender equality and women's autonomy as a threat to whether it's religion, culture, and what is seen as social norms. And these political attacks manifest in many various ways. And one of the ways, the first that I will look at, is through funding restrictions. Now, policy decisions that are made by governments affect access to sexual reproductive health rights. And we have seen in the recent past policy decisions that have been made, for example, by the US government and by the UK government, affecting access to sexual reproductive health services. We saw when the US had the global gag rule, and although now it's no longer in force, we live in that constant fear that if there is a change of regime, change of administration, and there is Republicans in power, that this may come back into effect. And we saw with that, with the implementation of the gag rule, a lot of clinics that were offering abortion services were closed. We saw, ability to organize as advocates of sexual reproductive health rights was completely restricted. We saw a number of civil society organizations, beyond the scope of the gag rule, even further self-censoring themselves and therefore not mobilizing, not organizing effectively. We also saw that, institutions that were charged with implementing the gag rule were overreaching. And this generally created a hostile environment, which on the other end helped to build a much stronger opposition to SRHR, including, investment in groups that are out there to oppose sexual reproductive health rights. We also saw that when the UK, withdrew its funding, that this had a ripple effect, and quite a bit of services shrunk, particularly services that were affecting sexual reproductive health rights. So government policies can affect, even though it's not that particular government, but governments such as the US and UK that are big, significant contributors of global health, the decisions that they make have a ripple effect across the globe. Secondly, we have also continued to witness a lot of disinformation and misleading campaigns. A lot of the framing of these campaigns and what we are seeing, these are strategies that have been tested in the US, have been tested in the Latin America region, and these are the same things that we are seeing replicated in Africa. Same framing, whether it's, they frame it as attack on family, and using the same tactics. We have seen these conservative groups, using their digital platforms, which are global in nature, to perpetuate disinformation and misinformation. Using this tactic, they have distorted medical facts, they have promoted myths about abortion and contraception, and they're using emotional appeals to manipulate public opinion. We have also seen that, they have tried to mobilize the public against political leaders who are in support of sexual reproductive health rights. In my own country, Kenya, we have witnessed them, identify members of parliament who support sexual reproductive health rights and threaten to mobilize people so that they can be recalled and that they may not be re-elected again. Again, at the global level and cutting across to the national level, we are seeing a lot of rollbacks in the protections and policies, where there have been policies that are protective of abortion rights, or where policies have been silent. We have seen that governments are going out of their way, to create policies that take back the gains that we have made. In Kenya, for example, for a long time, we had a reproductive health policy that allowed for access to sexual reproductive health services for adolescents without parental consent. But now this policy has been revised, and now there's a requirement, a mandatory requirement of parental consent for all SRH services, which is a retrogression that you don't expect at this particular time. We have also seen, how governments are using legislation and executive orders to take back, the gains that we have made. We can also not forget the implications of judicial pronouncements, such as, the one in Dobbs versus Jackson in the US, which appended the Roe v. Wade decision, and which has had a ripple effect across the globe. In many parts of Africa, there has been that sense that the US is where rights were protected, is where, there was liberal protections. And so if we are seeing these struggles within the US, then what does that mean for the rest of us? And we must stand up and distinguish our own context from that of the US. We have also seen a lot of, legal restrictions, whether it's in terms of the legislations that are made. And I think the most recent one that I must speak about is the draconian anti-homosexuality law in Uganda, which basically just criminalizes LGBTQ people simply for being. We have also seen a lot of laws that have targeted comprehensive sexuality education, laws that also target access to contraception, particularly for adolescents. At the same time, those who are opposed to abortion services and reproductive health services broadly they want to make sure that even where laws are progressive, or even where there is limited access, that healthcare providers are not able to provide those services, and that these laws remain only laws on paper. And so we have continued to see attacks on healthcare providers who are providing these services. They have been harassed. A number of them in many countries have been taken through judicial processes. And we have also seen the conservative groups attempting to introduce burdensome regulations or requirements that make it difficult for abortion clinics to operate. We saw that in the US, and we have seen that tactic replicated in Kenya, where we currently have a High Court case against Mary Stopes Kenya and others, and the government, a case that mirrors the case in the US that is basically trying to introduce unnecessary and burdensome regulations so that access to abortion is restricted. At the same time, we see, targeting of civil society organizations that work around the protection of bodily autonomy. We have seen the disproportionate auditing of organizations as a means of controlling and curtailing operations. We have also seen arrests and physical attacks on activists, to the extent that activists, who are associated with LGBTQ rights have been arrested and have been taken through tests to prove that whether they are homosexuals or not, and tests that are humiliating, that are inhuman, and that are degrading. We have, as I've also said, seen the introduction of the Uganda anti-homosexuality law more recently, which introduces new crimes such as the promotion of homosexuality, where anyone who is advocating for LGBTQ rights, including representatives of human rights organizations or those funders of LGBTQ rights, could face up to 20 years imprisonment. We see that on the one hand, as we are continuously disempowered and excluded from these spaces, and which spaces now conservative groups have entered. We are seeing them sitting around the decision-making spaces, whether it's within ministries of health, whether it is within governments, and the spaces that we had, the voice that we had, we are seeing them gaining more traction in those spaces. But I must say, it's not all gloom and doom. There is a lot of challenges and there's a lot of work for us to do. But organizations and communities have continued to organize. We continue to resist at all levels, national and global. We have continued to see, the use of litigation to challenge and to hold governments accountable. And we have also seen, as Samu has said, young feminists really organizing, and they are really, we believe that it's important for young feminists to organize for us to hold this fort, because this is a long fight that we will not finish tomorrow. We also must occupy, the political decision-making spaces. As women, political representation continues to be very critical for us so that we are in the room when these laws are being discussed. We must continue also to hold states accountable for the gender commitments that they continue making at the national level, at the global level. And I think also, as CSOs, we must continue to organize, and we must count on each other for solidarity across the globe. Because as I said earlier on, the tactics that are employed in Africa, for example, are not new tactics. It's the same things that were used in Ireland, it's the same things that are used in LAC, in the US, and across the globe. We must learn from each other, we must build solidarity, we must hold the fort until we win and we get protection for all human beings. Thank you very much.
Thank you so much, Evelyn. Great. Really, I think moving words to really communicate how urgent this is for individuals, that we cannot continue to allow this colonization of people's rights and their health. Thank you so much. And now we're going to turn to Kimberly Cocon. Kimberly is a young activist with Alian Misar, a Guatemalan organization working with Indigenous women and girls for the defense, promotion, and full exercise of their sexual and reproductive rights, including the right to access culturally relevant reproductive health services. Indeed, this group is fighting colonization right now. Alian Misar is also one of FP 2030's pioneer NGO commitment makers in the Latin America and Caribbean region, whose hub was announced just a couple months ago in Panama. Kimberly, thanks for joining us.
Muy buenos días.
Yes, good afternoon. I'm Aileen Ocon. I am 13 years old, and I'm a human rights activist for girls, for women, and I'm from Guatemala. Reproductive and sexual health is a taboo. Talking about reproductive and sexual health is a sin for conservative people. It's a topic that is being discussed in private board. People don't talk about that at home. So we still need to fight a lot in order to provide the right information to families, to people about about all of that in order to prevent pregnancies. The next slide, please. Cultural resistance. Many believe that the indigenous people culture has a lot of problems. From the Mayan cosmovision, there are different forms in order to avoid pregnancy and pregnancies that are non-desirable, but the patriarchal system and the sexist system and the armed conflict have taken over, but we are trying to fight that with medicines because the state does not even reach to all these Mayan communities. Next slide, please. Political context. In the political context, we do have the political constitution. We do have the law of internal protection of childhood and teenage age. We can find this in the law number 27, 2003. We do have the universal access law and equitative planification services. Unfortunately, all these laws are not being followed. We do need political will in order to follow them accordingly. The next slide, please. Sexual violence and reproductive violence. In Guatemala, there is a lot of sexual and violence, but we are only going to refer to moms that have from 10 to 19 years old. Maternal death from January to May in 2023 is a high number. It's concentrated in only 5 departments. La Paz, we can see 25 deaths. In Huehuetenango, 19 deaths. Quiché, 14 deaths. Santa Rosa, 13 deaths. Guatemala, 11 deaths. Those are the 5 departments with a higher number of maternal deaths. Next slide, please. And due to all these maternal deaths, we can see that this is an average of 230 kids that are orphans that will grow up without a mom, and that is gonna increase the morbidity, mortality, poverty, and malnutrition. This is a violence to women's rights. No one deserves to die without achieving their dreams. Next slide, please. Everyone needs to stand up. No one has to stay behind. Thank you so much, Matias. Thank you.
Thank you so much, Kimberly, and thank you for illustrating the issues that are so real for everyone in your community in Guatemala, and thank you for the work you do there. Looking forward to talking more about this in the discussion. Just a reminder to please put your questions in the Q&A or in the chat. Next, we have Yvette Alal. Yvette is technical manager with Raising Voices based in Uganda. Her expertise is in supporting organizations to use SASA, which many of you may have heard of. It's an evidence-based community mobilization approach to prevent violence against women. Developed with a combination of theory, practice, and relentless optimism, SASA encourages communities around the world to personally and collectively use our power to create safe, violence-free communities for women. Over the years, SASA has been adapted and implemented in at least 30 countries by more than 75 organizations around the world. Yvette, over to you.
Thank you so much, Mary Beth. Good afternoon if you're joining from this part of the world. I'm based in Kampala. Good evening, good morning from wherever you're joining. I'm so excited to be here today. So yeah, just really to recognize that we are talking about a very challenging issue, which is really about decolonizing reproduction. And at Raising Voices, we are the authors of the SASA approach. And SASA is really one of those approaches that is available for preventing violence against women, and that deals very specifically with preventing violence against women. And we do this by mobilizing communities to change social norms that perpetrate violence against women. So SASA was developed in 2008 in Uganda at a time when the public health sector was intensely focused on HIV response, and many social justice actors directed their advocacy efforts towards addressing structural drivers of the HIV pandemic. But by explicitly drawing attention to the interconnections between violence against women as both a cause and consequence of HIV, SASA also aspired to reduce women's vulnerability to HIV transmission. However, as SASA expanded to new contexts, including those with a low HIV prevalence, this component has been less resonant. And in addition, even in settings where HIV remains very critical, a very critical aspect of decision-making for women, such as, sorry, let me repeat that. And in addition, even in settings where HIV remains prevalent, Raising Voices has found that focusing on HIV prevention could, of course, really obscure the focus on women's sexual decision-making. So because of the lessons that we have learned, Raising Voices has revised the SASA approach into what we now have as SASA Together, which focuses very specifically on women's sexual decision-making, and also really focuses on issues that are very important for women that emphasize women's bodily autonomy, including consent for sex, pleasure, and bodily autonomy. So the salience of these broader issues emerged very strongly during the consultations that we had as we were trying to revise SASA. We did quite a number of consultations with a lot of people who were already using the approach. And one of the things that we found really is that partners observed, for example, that while conversations in using SASA around power and gender norms expectations were beginning to shift in the community, women and men really lacked the key skills that resonated very well with their intimate relationships. So based on these insights, SASA Together elevates sexual decision-making as a core theme, replacing the previous concept around HIV. And importantly, this new area uses an aspirational framing that highlights three aspects that are universal in most relationships. That is really around how we can all feel valued, how we can all feel cared for, and how we can feel respected. And of course, we find that whenever we focus on these issues of feeling valued, cared for, and respected, we, in a very direct way, are helping to build women's autonomy and to really resist some of these ideas that have existed in our communities for a long time. Of course, like the previous speakers have said, these ideas that came around the colonization of bodily autonomy. And reallywe find that this over time differs from the previous focus of the SASA approach, which was around reallocating household gender chores, which was frequently met with resistance, frustration, and a temporary surface level change. So when we do focus on these areas, we are really finding that this is helping to shift the discussions and to shift the power dynamics from the gender roles, the sharing of gender roles between women and men, into what really resonates, what's important for women and men, and for women especially, which is around the values of feeling respected, valued, and cared for. And so quickly, I just wanted to highlight those as one of the key aspects of the SASA approach that helps to connect with the topic that we are talking about here, which is really around building women's power to make decisions around their own bodies and to empower them to push back on some of these aspects, on some of these norms that have long prevailed in our communities, that have curtailed women's ability to make their own decisions over their bodies. So thank you very much.
Thank you so much, Yvette. And again, I think I love having that example of Sasa because it's just such a tangible way of resisting that reproductive violence and constructing a new kind of way of relating to each other and overcoming the centuries of oppression and colonization. Finally, we're going to hear from Sivananthi Thananthiran. Siva is currently Executive Director of ARROW, where she has co-authored ARROW's ICPD plus 15 and ICPD plus 20 Asia Pacific monitoring reports. And she's written numerous articles on women's sexual and reproductive health and rights. She's been able to expand the work of ARROW to examine more closely the interlinkages of sexual and reproductive health and rights with critical development issues such as poverty, food security, climate change, and migration. Under Siva's leadership, the organization's working partnerships have expanded to 17 countries in the region, as well as regional and global networks and organizations. Siva, welcome, and over to you.
Thank you, Mary Beth. I wanted to thank you all for choosing this very, very important and pertinent topic on decolonization. And decolonization in the field of sexual and reproductive health and rights can be tricky, because as we can see historically, women's bodies have been used for the colonial purposes, right? We have seen historically both in that of slavery and different forms of enslavement or enslaved labor, pregnancy, birth for women of color and women in the global South has been an experience fraught with violence and coercion, either to reproduce in numbers for the benefit of colonists, free labor, or for the nation state, as we see in a number of countries now. At the same time, in the 70s and 80s, fear of the population time bomb saw that coercive contraceptive practices became a norm, especially in the region I come from, which is the Asian region. The colonization process, we have to ask, have they truly left our shores and our minds? There are residues of colonization in the systems and in the institutions at the country level, and these are apparent in a number of ways. In this decolonization calls us to challenge power, the patriarchal, the colonist, the capitalist systems still embedded in our systems and our mindsets that are prevalent in our societies, especially around sexual and reproductive health and rights. I wanted to bring to mind, three marginalized groups and how colonization continues to be dominant in the way we treat them, right? Migrant workers is one, and the migrant workers' bodies are the new bodies being used for labor in our countries, right? And migrant women workers face undue sexual harassment and different forms of sexual violence and are discriminated against based on their HIV or their pregnancy status by different countries. And migrant women workers are also denied rights, to have children or to be able to enjoy, a family and have a family. Many of those who are citizens, and we know that we can see this debate being very vociferous at country level, will find that when we are talking about the agency and autonomy of and the sexual and reproductive health of migrant women workers, they are often denied that on the basis that their bodies are tied to that of the needs of the employers and the wishes of their employers. And, and in a number of countries, we can see the term modern day slavery being used for migrant labor. right? So including migrant workers within social services is a political conversation, which is very divisive in many countries, right? And this is where we also, have to use and unpack, the concepts on citizenship and the attainment of sexual and reproductive rights tied with this concept of citizenship, if we really wanted to begin the decolonization process of some of the previous speakers have also mentioned is actually on young people, right? And again, young people are thought of being incapable of decision-making on relationships and bodies, right? And young people's bodies are seen as the extension of their own families, wishes on what they should do with those bodies. And young people are denied information, comprehensive sexuality education, and services consistently across countries. Their confidentiality is often breached, and they're routinely denied services. So women also have faced this countless times, and with women, I would like to particularly mention, the impact of obstetric violence, right? Because women are seen, especially those who are lesser educated or who are poorer, face obstetric violence, and this is little about, right? I mean, their women's agency, autonomy, respect, privacy, dignity is not given to them. So women who are giving birth are routinely, they're assaulted, they're slapped, they're hit, and they're treated, like animals, within the process. So why does that happen? Why do service providers think that we can actually treat, poorer women or women who are lesser educated in that way? So this is also, we have to unpack. Who is powerful within our system? Have we not inherited our thinking about power and hierarchy in society very similar to how the colonized processes thought about, right? So in that, we became in the societies, systems, and institutions that we created reflected, this colonial way of looking at power and looking at who has power and who does not have power.